Hi, this is Michael Melman. Now we're going to talk about reproductive pharmacology. We'll run through some of the high-yield drugs you need to know for step 1, as well as some of the pathology and physiology in relation to these drugs. Now, in both a male and female, we'll get gonadotropin-releasing hormone secretion from the hypothalamus that acts on the anterior pituitary. Now, gonadotropin-releasing hormone increases inositol triphosphate, in the anterior pituitary. So when GnRH binds to its receptor, it increases inositol triphosphate. And it should be pointed out that it's pulsatile. So these pulses, that's stimulatory, whereas the continuous GnRH is inhibitory. Now, in physiology, we don't have continuous stimulation of the anterior pituitary by GnRH, but as we'll talk about, we have drugs that are used for this purpose. But for physiology purposes, know that pulsatile GnRH is stimulatory, continuous is inhibitory. All right. So if we have pulsatile, that's going to increase our FSH and LH. Right. That's going to increase it if it's pulsatile, whereas continuous will decrease our FSH and LH. Okay. So inositol triphosphate will increase intracellularly with gonadotropin releasing hormone stimulation at the anterior pituitary. Now, follicle stimulating hormone and luteinizing hormone, now when these bind to their receptors at the ovary and the testes, they increase intracellular cAMP. All right. Now, what you need to know is that these hormones work side by side, where in the woman, the luteinizing hormone will act on theca cells, theca interna cells. Now, these theca cells, in response to luteinizing hormone, they're going to secrete androgens. All right. Now, these androgens, such as androstenedione, testosterone, we're going to have our FSH from the anterior pituitary. That's going to act on granulosa cells, and granulosa cells secrete aromatase. All right. So aromatase is what is going to convert these androgens into estrogens. All right. So luteinizing hormone acts on theca cells to produce androgens. The androgens move into the granulosa cells. All right. So the androgens produced by the theca cells will move into the granulosa cells, where aromatase within the granulosa cells will convert the androgens into estrogens. Now, androstenedione will be aromatized to estrone, and then estrone can be converted to estradiol. Or you can simply have the conversion of testosterone directly to estradiol. So you can have androstenedione be converted indirectly to estradiol via estrone. Now, estrone is a weak estrogen. Estrone can also be a storage form of estrogen if you add a sulfate group onto it. Estrone is also one of the most prevalent types of estrogens in postmenopausal women, because in postmenopausal women they have less estradiol. So estrone is the predominant estrogen in postmenopausal women, but it's a weak estrogen in general. Estradiol is our strong estrogen. And so these are our aromatization processes. That aromatization, that's the same in both males and females. For these physiology purposes, it's the luteinizing hormone acting on theca interna cells in the woman, whereas the follicle stimulating hormone acts on granulosa cells. Whereas in a man, the luteinizing hormone will act on Leydig cells. All right. And the FSH will act on Sertoli cells, and it's a similar process. Similar process where Sertoli cells will secrete aromatase. Now, the Sertoli cells also secrete Müllerian inhibitory factor during embryological development. So they secrete androgen binding protein, inhibin. Okay, so they secrete other factors as well. But in general, this is where your androgens are coming from, your Leydig cells. And if you have your Sertoli cell, okay, so if you have your Sertoli cell, your androgens will pass into the cell, and aromatase will convert these into estrogens. Okay, so it's pretty straightforward as far as that's concerned. And just don't forget that it's pulsatile GnRH that is stimulatory. It's continuous, that's inhibitory. The inositol triphosphate is what increases with GnRH acting on the anterior pituitary, and it's increased CAMP that is a result of FSH and LH secretion. Okay. Now, leuprolide and goserelin are both gonadotropin-releasing hormone receptor agonists. Okay, and the extremely high yield point is that they're agonists. Okay, they're agonists. They have inhibitory effects at the GnRH receptor, which means that most students forget the fact that they're actually agonists. Now, how can you be an agonist at the GnRH receptor and have antagonistic effects? How could that happen? Right, so if you're a continuous agonist, or if you're continuously administered, you'd have an inhibitory effect at the GnRH receptor, which is what happens. So leuprolide is exceedingly high yield, very, very commonly seen in questions. And it's an agonist. Many students get that wrong. They'll choose antagonist. Now, leuprolide is given continuously for, as you can see here, prostate cancer or uterine fibroids, okay, because we want that inhibitory effect. But for infertility, we could give it as pulsatile because we'd have our respective differences in LH and FSH, where if it's continuous, we'd have decreased LH-FSH secretion. If we have it pulsatile, then it's increased. Okay, so once again, it's an agonist. And fertility, that's relatively straightforward because of our increased LH-FSH. And prostate cancer is insanely high yield for leuprolide. All right. Now, this isn't just memorize leuprolide and prostate cancer. Okay. The reason I'm also being explicit about this point is because the USMLE commonly likes to throw in finasteride as a drug as an answer for the treatment of prostate cancer. Okay, finasteride is a very good answer if BPH, benign prostatic hyperplasia, is the pathology. Okay, we have drugs such as tamsulosin and finasteride that are used for BPH. Okay, BPH, right? Now, finasteride inhibits 5-alpha reductase, so we don't get our DHT, and our DHT, dihydrotestosterone, is contributory to BPH pathology, all right? But that's not the case here, so you need to know that it's prostate cancer, not BPH, that we use leuprolide for, okay? So prostate cancer, leuprolide, all right? And would it be continuous? Yes, okay, because we don't want the stimulation of the prostate gland. We'd want decreased testosterone, dihydrotestosterone acting on the prostate gland. And it's a therapy that we use for the cancer. Similar with uterine fibroids. Now, fibroids are, you need to know that they are sensitive to changes in estrogen. Okay, so they wax and wane with the menstrual cycle. During menstruation, they'll wane. Post-menopause, they'll wane. But during ovulation, they might become painful and lead to bleeding. Usually a large, bulky uterus. Okay, but we'd give leuprolide continuously to treat the fibroids. Now, these fibroids, because they're estrogen sensitive, if we give leuprolide, which would decrease LH-FSH, then we'd have decreased production of androgens, and which would mean that there's less androgens to aromatize an estrogen. We get decreased estrogen. So that's pretty straightforward as well. And precocious puberty. We'd give continuous, such as in McCune-Albright syndrome, so where we have precocious puberty, and cafe au lait spots and coast-to-main distribution, polyostotic fibrous dysplasia. That's just an example. But precocious puberty, as in puberty that's has an onset much earlier than expected, we could use leuprolide for. Okay, although these uses are high yield, it's the mechanism that's equally high yield. Okay, so you need to take away from this that it's an agonist and not an antagonist. Okay, despite the fact that it has inhibitory effects at the anterior pituitary. We're going to talk about estrogens. These are just some examples of estrogens. Mestranol has been used in oral contraceptive pills in the past. Diethylstilbestrol, USMLE likes you to know that that's associated with vaginal clear cell carcinoma. Okay, vaginal clear cell carcinoma. Okay, that's very high yield. DS used to be given to some women during pregnancy to treat vaginitis, and it would actually result in vaginal clear cell carcinoma in their daughters 30 or 40 years later. Okay, so USMLE will give you a vignette of a woman who's 30 or 40 years old, and she has a vaginal clear cell carcinoma, and it'll be diethylstilbestrol that her mom had taken 30 or 40 years earlier during pregnancy. Okay, so USMLE likes you to know that. And estrogens, they bind to intracytoplasmic receptors. Okay, so one of the things USMLE likes you to know is that steroid receptors in general tend to be intracytoplasmic. Okay, it sounds like a superfluous detail, but it's actually not. Steroid receptors are intracytoplasmic, like testosterone is intracytoplasmic. Okay, cortisol would bind to an intracytoplasmic protein. Okay, aldosterone is a steroid hormone that would bind to an intracellular receptor. Okay, so your steroid hormones are intracytoplasmic. Now the exceptions are T3 and T4. Okay, occasionally you'll see vitamin A grouped in this category. These are intranuclear receptors. Now, the net result of all of this is increased gene transcription, so increased gene expression. They're slower acting. Okay, it's not like they just bind to a receptor and you get an instant response. That's why steroids take time to work, right? So you're treating asthma, you give your short-acting beta 2 agonist, such as salbutamol, and you give steroids. You can give a low-dose inhaler, and they take time to work. Okay, so and there's a reason for that. Okay, so they increase gene transcription. Estrogens can treat hypogonadism. So if we had hypogonadism, what would primary hypogonadism be? What would that mean? It would mean our problem is with the testes and ovaries. Okay, testes or ovaries. All right. If it's primary, it means it's a problem with the that organ itself. Whereas secondary hypogonadism is a problem with the anterior pituitary. Okay, so these are where our problems are. So anterior pituitary is the source of the problem in secondary hypogonadism. So it would be decreased LH or FSH, okay, or both. Or we could say a tertiary hypogonadism. Could you think of what would cause that? So the problem would be with the hypothalamus. That's an example. Such as Kallmann syndrome. Okay, so Kallmann syndrome, that's where we have anosmia, inability to smell. This is X-linked. inability to smell, due to failure of migration of the olfactory placode, as well as the GnRH secreting neurons. Okay, so this would be decreased GnRH. So now we can briefly touch upon ovarian failure. Now, premature ovarian failure would be when a woman has menopause before the age of 40. Okay, USMLE is not going to ask you the date, but in general, you need to know that if you get a question and they mention menopause or loss of periods before the age of 40, then we're talking premature ovarian failure. And the one hormone that's most important in indicating that is increased FSH. So that's what increases most significantly even in menopause as well. Are you going to get increased LH? Sure. Okay, you're going to get increased LH. You'll have decreased inhibin, okay, decreased androgen and estrogen production. But if they ever ask you for the hormone that is best reflective of loss of menstrual cycles, it's FSH, okay, because that's associated with the development of the eggs and the maturation of those follicles. So estrogens can also be used to treat menstrual abnormalities. Okay, so if a woman has abnormal cycles, she could be given OCPs, for instance. Okay, that's a common treatment. Hormone replacement therapy in postmenopausal women. Now, what they want you to know for this is that sometimes they'll ask you the indication. They'll say, when would you give estrogens? When would you give hormonal replacement therapy in postmenopausal women? And they'll give many tempting answers. Like they'll say treatment of osteoporosis, for instance, which technically estrogens would mitigate the progression of osteoporosis. Okay, but the answer they like are vasomotor symptoms. That's how they like to phrase it, which just means like hot flashes. Okay, hot flashes, vaginal dryness. Like if there's severe, like most women will get these symptoms anyway, but if a woman has severe symptoms that are really affecting her functioning, that is one of the best indications for hormone replacement therapy. We try to avoid hormone replacement therapy in general, which we'll talk about. Okay, and the reason for that is because estrogens carry risks. Okay, now in some ways they're protective and helpful, in other ways they're deleterious. Now there's an increased risk of endometrial cancer. Okay, now unopposed estrogen. Unopposed estrogen is always the mechanism, the highest yield mechanism for endometrial cancer. Obviously, you can have genetic susceptibilities such as BRCA1, 2, HNPCC, but unopposed estrogen leads to endometrial hyperplasia, increased cell turnover, increased risk of cancer. Endometrial cancer, usually perimenopausal, 55 and older. It's the diagnosis in a postmenopausal woman until proven otherwise if she has vaginal bleeding. Okay, you always have to rule out endometrial cancer. But estrogens increase the risk of that. So, as we talked about, this is very high yield. Okay, no more to explain there. And also increased risk of thrombus and MI. Okay, so we get increased, estrogens increase factor 8. They also increase the conversion of fibrinogen to fibrin. And there's quite a few theories / mechanisms out there, but also activated protein C resistance, which proteins S and C are anti-coagulant proteins, whereas the APC resistance can lead to increased thrombus and MI. There's about a twofold increased risk of MI with those given OCPs versus those not given OCPs. And this would be increased risk of DVT. So we do not like giving estrogen-containing oral contraceptives to women who have coagulation disorders or those who smoke. Okay, those are reasons not to opt to give estrogen-containing medications to these women. Okay, because we don't want DVTs, obviously. For the flash quiz, what will be the hormonal effect of continuous leuprolide or goserelin therapy? Okay, so the answer is LH and FSH first rise, then fall as desensitization of GnRH receptor ensues. So, as we talked about, continuous is inhibitory, okay, whereas pulsatile is stimulatory. Okay, but one of the clever tidbits here is that occasionally the USMLE will mention a drug where they might even give it to you in graph form, where they'll say a drug was given. They'll say like these are your like LH, or they'll say FSH levels, and they'll say this is time, and they'll say the drug was given, and they'll say drug was given here. That type of curve. This is when the drug was given. So just erase that second. So if the drug is given here, and it's continuous, at first it's going to increase the LH and FSH because it is acting on the receptor. Leuprolide and goserelin are agonists, okay? And then the receptor desensitizes and we lose that secretion.